in risk adjustment, maximizing accuracy and compliance. I am your host, Michelle Zilish. I am the Senior Director of Product Management at Innovaccer. Joining me is our wonderful panel today from my colleague, Dr. Jan, Chief Innovation Officer at Innovaccer, Shri from Longevity Health Plan, and Christy from UST Health Proofs. So we're very excited to have everybody here today to talk about this topic. We've got a very quick agenda to go through, so we'll be discussing a little bit of this today. But what we'll start with is discussing some of the way AI is changing in the risk adjustment space. We know that there is at least 80% of patient data resides in unstructured formats. And with it, we're seeing a lot of changes with AI helping to support NLP extraction of those unstructured notes to help with diagnosis coding, assistance with coders in being able to have the HCC codes suggested to them, and a lot of effort in prospective and retrospective risk adjustment to identify gaps of care and making sure those are getting closed, but also some of the predictive analytics. And as we go through, we're going to talk about some of those things. One of the things that I do want to talk about from your perspective, what is the role of a clinician, Dr. Jane, in helping to develop effective AI strategies to enhance that diagnosis accuracy and making sure during the prospective concurrent reviews, we're not seeing a lot of noise and making sure that patient outcomes remain unaffected?
Well, look, we know that having a human in the loop is incredibly important when it comes to AI strategies and AI development. And it's even more important when we think about diagnostic accuracy. Having clinicians in the loop can also help identify what are the key data points you need that need to be flagged in order for us to sort of lead a provider, for example, to the conclusion that there might be a missing diagnosis on the record. That requires a review of the clinical information, identifying which are the most important pieces that are relevant for that clinician or that clinician's team to be saying or surfacing up this particular diagnosis. I think it's incredibly important that it's not just about developing processes in which you have clinicians in the loop, but creating transparency so that those clinicians understand why is the AI system, the AI algorithm, if you will, why are they suggesting these particular diagnoses, being able to click on something and seeing here's the evidence behind it that might be buried in the electronic health record, might be buried in a prior claim record, et cetera. So having clinicians in the loop, if you will, really solve three fundamental problems. It creates a level of diagnostic accuracy because those clinicians really understand how those diagnoses come to be. It creates a level of transparency that's going to be critical in how we might be approaching these things. And I think it also creates a level of buy-in. Creating that partnership between the clinicians and the AI algorithms increases the chances of very good adoption when it comes to rolling these types of programs out. I hope that helps, Michelle.
It does. So speaking of that transparency, Christy, how are you engaging your providers with making sure that they have that transparency?
Absolutely. So remember that AI supports, not overrides clinical judgment. So a strategy that we use here at UST Health Proof is we embed our medical directors into this process. So our medical directors are also CRC certified coders, and we require their approval to ensure that clinical accuracy, but it's also super important to make sure that we get their buy-in to make sure that we are reducing that potential provider abrasion. So for example, the NLP might be using medications to support a diagnosis. But are these these assumptions, are they correct? Are they clinically accurate? Are the labs that the AI is using to support that diagnosis, are those correct, right? We don't want to see an A1C being used to support, something that's not related to diabetes. So we got to get that approval from the clinician to make sure that we can cover it there. And this way, there's the ability to kind of provide that peer-to-peer perspective, and that'll allow us to accurately document that member's burden of illness. And then the outcome there is going to be better diagnosis specificity. So shout out to V28. We all are aware we're fully implemented for 2025 dates of service, right? Specificity matters. There's a lot of challenges there. It's very easy to click the unspecified, but we need to get that level of detail. And the AI is where we can go to kind of help us ensure that we're accurately capturing that member's burden of illness.
Correct. Love the V28, much more helpful with getting that specificity. Shri, how are you at Longevity really ensuring that you're maintaining regulatory compliance and integrating that AI into your workflows and making sure that you do have that transparency and that the physicians are getting that documentation done completely with the correct specificity instead of taking the unsupported or unconfirmed?
So interestingly, a good question, Michelle. I am actually part of a cohort of physicians, part of the Harvard Medical School AI program. Very interesting question because all of them are grappling with that same kind of understanding. One is people feel that something is going to take over, AI is going to take over what I do, or have the philosophy that that's something that they're going to get from AI is always truthful. And what we are learning together is it's not about the data that's coming together to make sure that the data is accurate, data is valid, data is labeled correctly, so you can provide the right predictive analytics, whether it be in risk adjustment or even for clinical judgment, right? So it gives that a background of how you look at AI. On our side, one of the things that we've always felt is from a compliance perspective is everybody seems to think that if you get something from a technology solution, it should be accurate, right? But that's not true all the time, every time. And that is a big mistake people make. And the challenge is for us to help them understand how is it compliant? What is it that we need to do to make sure it is compliant? So we have to make sure that it has all of the PHI, HIPAA, those kinds of requirements that's met appropriately so that when we share the information to the clinician, they understand, yes, because we are very transparent with our clinicians. We say, look, this is where we get the data from. This is what is being shared. And this is how the algorithm is working in order to get the data to your hands. And the other very important aspect of that, what we do is it's a choice. It's not like shoving it in your face, right? It's a choice. We give you opportunities for you to understand what is the solution telling you, rather than saying, here is the solution, here is the answer, use it. That's not the way it helps. So it gives them the ability for them to get some, what we call clinical judgment. And as they use clinical judgment, have this as a, going back to, I work for an institutional special needs plan, so we get a lot of elderly patients. And I use that as a walking stick, right? So you got a walking stick as a helpful piece, not yes, because that's what you got to do, but use that as a way to help make clinical judgment better, faster, and in a compliant way.
Perfect. Dr. Jain, how do you see that? And as you advise many of our clients at Innovaccer and work with others in the industry, how are you seeing that regulatory change?
Well, I think Shree's absolutely right. He mentioned HIPAA. So let's all agree that it first starts with a very strong data governance. You still need to manage the compliance around HIPAA. Just because you're using AI doesn't mean you can skip that fundamental step around privacy. The second thing that I would probably recommend, and I have recommended to organizations, is really thinking through where is CMS going with Medicare Advantage and the use of AI and risk adjustment? What are the guardrails that we should be thinking about? And having spent a long time doing AI in my career, one of the things that we typically say, and you start to combine that with my medical background, where do no harm. Let's make sure we are being equitable in the way we are approaching risk adjustment. Let's make sure that we're not introducing any bias into the equation, if you will. And that could be any number of different ways that it can happen. It can happen because we are training the system with a data set that perhaps already has some intrinsic bias in it. So the first thing is just providing some level of assurance that when we think about how CMS has been proposing some of these rules around the use of AI, that we are creating an environment, just as Shri said, that we're providing transparency, the physician is making the final determination, and that we're not introducing any unexpected bias or health equity issues that might be part of the equation. I think one way you do that, I've been advising folks, is to set up an AI governing process, just like we do here at Innovaccer. We have an AI governance steering committee, making sure that there is a place where people can go and hash out some of these issues in advance of trying to make decisions for it. And I think just watching the space very carefully, where's CMS going? Where is the federal government as overall from an HHS point of view going? Where are the regional and community standards going in terms of the use of AI? And then, of course, I'm a big fan of incorporating as much of the clinical and the clinician's voice into the regulatory training and the regulatory process. Nothing better than for clinicians to hear from other clinicians about the guardrails and why they're important. I think time will tell whether those guardrails are going to stop us from getting the advantages of AI. But so far, what I've seen is that we can still walk and chew gum at the same time. We can get the benefits of the AI and still comply with some of the regulatory challenges that are going to evolve over time.
Perfect. And Christy, how are you responding to those regulatory changes? I know with all of the risk adjustment coding, you've got to be keeping an eye on what CMS is putting in the advanced and final notices. How is it impacting you and your strategies?
100%. So I'm a coder. I always say that, especially when I'm on a panel with people in technology. I'm a coder at heart, so compliance is near and dear to me. So as far as implementing an AI or an NLP, you've got to make sure that you involve your compliance team, right, in every single stage of the AI integration, especially during algorithm validation and any kind of code acceptance threshold. You should also be involving your technology department to approve any AI use so they can help identify any showstoppers from like a techie point of view, right, prior to onboarding. We also need to ask, is the AI capable of continuous learning? What is the current F score of the results? So that F score is a score that essentially measures the predictive performance of that AI software. The higher the value, the higher the consistency and performance of the AI. You've got to build those guardrails into your workflows. When setting up the project with the AI, are the settings configurable? So we talk about how these regulatory rules come out. We've got to be able to adapt, and we have to adapt quickly. Is your AI set up to adapt quickly? Can you configure those settings? Is your AI set up to adopt coding guidelines, right? That's another way of continuous learning. For us, we have a number of clients, and they each, have their own little flavor to how they like us to capture. So some will prefer us to utilize, unlinked medications, or some will say we need it to be linked. So we can set and configure that AI to make sure that the client's individual coding guidelines are taken into account when they're flagging those diagnoses as well. And then, of course, coders go through, they're reviewing that output of the AI before any diagnosis code is submitted. So at UST HealthProof, nothing flows directly to submissions without coder review. I know we touched on this a little bit earlier, where we like to think we can trust technology 100%, but as we know, we don't want to, I'm in Vegas, but I'm not betting on that, right? When it comes to compliance, we have to be 100% sure that what we're submitting is compliant. And what that means is we've got to have some folks looking over those results to make sure that they are in fact compliant with CMS guidelines. You've also got to make sure that you're routinely reviewing those settings. What support is it using? If you're using a vendor and someone asks you, hey, how is your NLP structured? And you're like, I don't know. No, we got to know, right? What is it using as support? What medications is it using? Where in the record is it looking? Is it pulling from the social history? Is it pulling from family history? So all of those things. And then we've got to make sure that we follow that up with periodic audit sampling, right? We want to compare what that AI is recommending versus what the final coder submission looks like. See where it aligns with RADV and OIG expectations. But also it's a great way to not just train your AI, but if the AI is performing well, there's also some areas where you might be able to educate your coding team. So it's, it's dual learning. There's continuous learning on both sides. And then, of course, collaborating with your legal department and, again, the compliance teams during that vendor evaluation.
So
Another
talking
thing
about
to
that,
add, Michelle, is if you look at where we've come in the healthcare realm space, right? We had data in our EMRs, which we used. We had data from claims that we used, but these were what I call islands of information, not integrated in a way that could make sense. Now we have HIEs that we can integrate as well to make it work. So that also is something that we could utilize and benefit from there. However, all of this data is not clearly labeled, have functional features in them, or have been verified and validated, right? Now,
as I said, right, you take data that's out there and you just let it all suck it up. And now we go, okay, give me some nice predictions. And it's going to give you predictions as dumb as it can be, because it's learning from what data you feed it. And healthcare is notorious for not having the right clinical notes. Nothing wrong with clinicians, but that's the we've seen that before. Not having the right demographic data appropriately updated. Medication adherence is an issue, which we know for a fact. And then we've got hospitals, sometimes submitting data to HIE and sometimes not. So now you have data that's coming from several sources, which is fantastic. But at the same time, the completeness aspect of it is difficult to understand. Now, when you look at from a compliance perspective, is it compliant? It's compliant up to what you received, not compliant to everything that you could have got, which you don't know. So that's one, I always go back to that principle. It's compliant as much as you know, not compliant as to what it should be, because you don't know if you have got everything that's ingested by the model. And if you don't know what else the model requires in order to give you a complete package. Those are some of the things that I always tell them, technology is fantastic, but always take it with a pinch of salt, because it can always be wrong. Just because you type something in Microsoft Word doesn't mean that letter is right. There's always stuff that you can find out. Could be grammatically correct, but what could be culturally completely inaccurate. So think about those kinds of factors that we need to consider. And especially if you're looking at data from multiple countries. Now think about the cultural factors, the factors that is impacting what their society demands or delivers, and the demographic and ethnic factors as well that feature into how the data is mentioned or talked to by those clinicians in those countries. So there is a lot of variability, and we are just trying to get to how we think it's going to work. So we are literally scraping the surface. There's a lot more to get to.
As a follow-up to that, do you see a lot more of challenges with that transparency of getting your staff to understand and ask them, what should we be doing? What should we be adopting? What additional biases should we be eliminating? Are you working with that? And how do you get them to buy in as you start looking at adopting different AI models?
So we educate them on the fact that what you see is what you basically fed the beast, right? In a way, that's what we tell them first. The second thing is, you have to use your own judgment in reviewing the data as well, right? That's the second thing. The third thing is, don't just assume that this is a missing code that is an HCC that was not captured. Don't assume that it's not captured purely because it may have been hidden or missed through bias, and that would not have gone through to the system. And lastly, don't assume that the NLP is digesting everything and anything that you feed it, because it is also sometimes can be selective based on the algorithm deployed on what it ingests. So with all of those factors, we give them that background. So it is always good for them to understand. It's not everything, but it's it's definitely better than what you have today, because you have some knowledge today, not everything, but now you have some other additional knowledge and information that you can use to do better coding. I'm not a coder. Sorry, Christy. I'm a technology guy. So we can do better coding, obviously. We can give you better insight as to what the clinical output should be or should have been. We could give you what are the gaps that are missing that you probably have to take a look at. But at the same time, we're not going to tell you have to do this A, B, C, and D, and you'll be complete. We're not saying that, because there is some level of that, what Anil talked about, that human element is need to have that very important factor in this whole process.
We have a question from one of our attendees asking, what is the specific ways that AI models are being trained to avoid inherent bias that exists in healthcare? I'll let Dr. Jain, I know this is one that we've talked about numerous times, so I'll let you give your thoughts and then we'll let the rest of the group go, because it's a great question.
Yeah, so no doubt that there are not only inherent biases, but very explicit biases in healthcare. It's for lots of good reasons. I think the first step is making sure that the training data, the data that's used to train the different AI algorithms, comes from a diverse population, comes with diverse labeled data that Shri and Christy both spoke about earlier, that there is a wide representation of different scenarios that the data is going to be eventually used to train a model that's going to go solve those scenarios. Let me give you an example. Early in my career, when I was a doc at the Cleveland Clinic, was also involved in the IT shop and the data shops, and we were trying to build models that would be usable at community hospitals. Well, we have to be careful. You build a model at the Cleveland Clinic, a very large quaternary care center with the sickest of the sick in Northeast Ohio. How applicable would that be to a rural population of patients in, let's say, parts of Mississippi or Texas? So we have to be careful that the models themselves have enough transparency that we know how they were trained, so that we know that by including a large enough sample of a diverse population, that we eliminated some of the biases that can happen when you are looking at a focused population. That's one way. Another way is to do it is to look at the output of the models over time and see whether it starts to sort of signal that there might be bias. And there's many open source tools, many that Innovacer uses. My former employer, IBM, had built some open source tools to look for bias and issues that might arise from data sets in AI models. And there's a lot of smart people, data scientists, who have built lots of tools to look for those signals that might suggest that something is off. And anything can get off kilter over time because, well, human disease changes. Can you imagine building a model for hospital admissions pre-COVID and then trying to use that during the COVID time or immediately after? So we have to look for not only the intrinsic bias, but the extrinsic bias, size of the data, the diversity of the data, who supplied the data, who is giving you the data will also lead potentially to some commercial biases that might exist out there as well. But I think the broader answer is it's a very complex topic. Fortunately, there are a lot of smart people, a lot of tooling that's available for folks who want to dig into this. And it's something that is near and dear to, and should be near and dear to every AI governance committee that's out there evaluating tools and evaluating different technologies. And it's something that clinicians are becoming a little bit smarter about in terms of asking the right questions.
And Christy, with
When
regards
you
to
look
that,
at when you look at bias, what I've seen is as the AI model starts, when you start tuning the model, you can actually do proactive monitoring on that model itself. That allows you to eliminate that bias. So you can feed the, you can do agentic AI where you're actually looking at that model, doing proactive monitoring as the model is learning. That way you avoid that bias in a way, I mean, as much as you can, right? It's not completely, but it allows you to help manage the bias in a way that it's not overriding the decision that's being thrown out through the algorithm.
I think what Shri's saying is something incredibly important. First of all, you have to measure in order to even detect the bias. And I think there's always going to be bias in everything we do. We bring bias every time we make any decisions as humans. But if we're not measuring the outputs and looking for that, we're never going to see it. So when I talk to boards of health systems and colleagues of mine across the industry, I think the most important thing we can do is bring some of those open source tools and some of those proprietary tools that are monitoring. But where I think people are going to have, no light of, there's going to be absolutely no wiggle room is that if there are organizations who are not even measuring. That is a big no-no. There is going to be a world in which nothing's going to be perfect, as we've all discussed. Perhaps might be better than a room full of physicians, but definitely not perfect. They're going to look for systemic negligence as opposed to you've done all the right things, but something went awry. That's probably going to be forgiven compared to systemic negligence. And that's what I would say, that not looking for bias is systemic negligence.
great. Christy, we know coders, you can bring 4 coders together, look at the same documentation, you're going to have 4 different answers. with AI in there, how is that adding to the bias discussion now for you?
It all comes back to continuous learning, as we've been talking about, right? We need to provide that feedback to help train that AI machine. I think Dr. Jan covered it really well regarding the diversity of the sample, right? So if we're looking at, Ohio at Cleveland Clinic patients, they're going to be, much sicker than maybe the general population. Conversely, if we're looking at a sample of patients from, upstate New York or Connecticut versus maybe some that are in Mississippi or in Puerto Rico, where we know, state funding for healthcare can vary. You really got to have a diverse sample in order to work with that AI to help weed out some of that inherent bias that exists.
Out of curiosity, have you seen any difference in bias models based off of Medicare versus Medicaid and the commercial models? And how is that impacting across the board now?
Oh yeah, and that trickles back into the first question about provider engagement. Like we really rely heavily on our medical directors to really guide us. And hey, this is saying one thing, but what does this mean? Or what is the AI trying to tell us? And then be able to provide that feedback. I think having the ability to interact with a clinician while you're reviewing these things across all different lines of business, whether it's state Medicaid or ACA or Medicare Advantage or anything is really important.
Perfect. All right. So one of the things that we're talking about is a lot of times getting that staff buy-in. What are we seeing as strategies and metrics to really know that the impact and buy-in for team engagement is taking there and not negatively impacting efficiency or accuracy or any compliance? Shri, how are you handling it there at Longevity?
It's an ongoing discussion with us. I can tell you right now, because it's new. That's one thing I can tell you. Everybody wants to get into it and everybody is afraid and everybody is trying to figure out what it is. So we start with just by explaining what we're doing, right? That's where we start, because what we have seen, and in my past life working with clinicians a lot, they are very inquisitive. They are searching for information and they want to understand how a particular decision was made. So irrespective of what we do, right, that is the approach you take. You have to give them options. You have to help them understand what was done and actually be transparent and show them how this was actually built out. That eliminates a lot of what I call fear that is coming from anxiousness, right? That's what they're anxious to know. And sometimes anxiousness turns into fear when you don't know or when you're not told. And then it becomes kind of what I call an immediate reaction of, I don't want to do anything anymore, right? We've seen that before. And engaging them ahead of time as part of, okay, here is what we're looking at doing. Here is what we need to do. Here are the codes that we see. Here is what we think is the options or problems that we see. And engaging with them literally changes the world. I can tell you right now, number one. Number two, educating them, right? What is it about? This AI thing, and machine learning. What is it about? Why is this such an important thing? How does it, because everybody's, oh my God, I'm going to lose my job. Something's going to happen, do it automatically, blah, blah, whatever, right? So help them go through that process. And then also help them understand, hey, we are able to find stuff that was missing before that is going to help you do a better job. Not just you as a person, but you as an entity for the organization. That is something that we also tell them. These things really help them get us on board. It's like, instead of carrying a luggage on your back, you have somebody else carrying the luggage with you that really helps you to move forward rather than dragging it along with you. That's the way we see it, and that really has helped us.
Perfect. And Christy, for you guys?
Yeah. So I'm going to bring it back to my first point of the webinar is that remember that AI supports, not overrides clinical judgment. So remember that NLP is there, this AI is there as a tool to support the coder. It doesn't replace the coder. And I think just having that general message and communicating that to my teams has been really helpful, right? Technology is not perfect, and we do need, the viewpoints of clinicians, of coders, to make sure that what we're abstracting and what we're reporting is, compliant with these regulatory guidelines. So for us, our coders and our coding leadership have been heavily involved in evaluating the AI particularly for NLP platforms, and providing that feedback for continuous learning of the AI model. So as the coders are reviewing these medical records and abstracting these diagnoses that are in accordance with guidelines, they're actively providing that continuous learning to the AI model. And as they do that, the coders will then build trust with that AI model based on the quality reviews for accuracy and completeness of those results produced. So it's a two-way street, right? The coders also have to trust the NLP. How do we do that? By using it. And to what Shri mentioned, which I think is a really important subject, is we're not just providing the AI with continuous learning, it can also help us. So in evaluating, it's like, oh gosh, we might have, captured hyperlipidemia unspecified, but it was actually a different specification of that. And the AI kind of helped train us. And then we can provide that education to our coders for their review. So it helps them feel more confident, and it helps them become a better coder.
Great. Christy, I know we're going to talk a little bit about use case for real world. Can you talk about how AI is really streamlining the process and improving efficiencies in your risk adjustment operations?
Yes. So for us, we contract with health plans. So we will get charts, all different kinds of charts, from handwritten to every single EMR you can possibly imagine. So with each of those, they're formatted differently. Some can show up for 50 pages, some are 10,000 pages, and coder's a human and we miss things, right? So being able to have an AI tool that can help guide the coder, again, supporting them and locating some of these keywords, really, again, provides efficiency when it's 10,000 pages, right? We're not spending 6 hours reviewing the chart. We have this tool to support us. So there's a level of efficiency with their productivity, right? So evaluating the impact of the AI as far as charts per hour pre and post AI implementation. What does that look like? It should always be an improvement, right? If you were doing 10 before and now you're doing 15, that's excellent. But then we've also got to make sure that we're not just efficient on the production side, but that we're accurate, compliant, complete, right? Accurate meaning what we're submitting, is compliant with risk adjustment coding guidelines, and complete meaning we didn't miss anything, right? We didn't leave anything on the table. We want to make sure, again, we're accurately capturing that member's burden of illness. It's very important. So we need to make sure that the NLP is providing the pass rates, right? We're at 95% or greater. Inter-rater reliability scores, team satisfaction scores, engaging, a way for the coders to report anything odd, that's going on in the AI that they see. Maybe it's linking, I don't know, lidocaine to breast cancer. Like, we don't want that association. We want to make sure that the coders have an ability to evaluate anything that's egregious live. And then escalations. So what kind of AI disputed codes are there? Again, using the lidocaine with the breast cancer example, we want to make sure that we're, ranking those as to, hey, this is pretty egregious. We need to address this, here. And by being able to do that, again, it increases our efficiency, charts per hour, but it's also in a compliant manner. Coder production increase means nothing if you're not compliant. Right? If you're I can do 1,000 charts per day. That's great, but what is the quality score? You don't want to put these health plans. The health plans bear the ultimate risk here of their submission. So we need to make sure that it's accurate and compliant.
And how are companies like Innovaccer helping you to make sure that you are being accurate and compliant?
Yeah, so we have been able to improve not only our completeness in code capture, but also our accuracy. So in risk adjustment, we can be so focused on accuracy at the category level, right? Because we get paid at the category level. But we need to be accurate at the diagnosis level too. It matters. So by working with Innovaccer, our QA audit time dropped. Since those AI pre-flagged gaps are pre-scored based on confidence levels. So AI can also be used to organize the chart reviews in order of, suspecting opportunities and, open gaps. So we're working together with Innovaccer on improved suspecting as well as our EMR write-back functionality that's supported by AI. And it's honestly been a game changer.
We have a question from the audience with regards to the coding perspective. There are emerging roles on the horizon that integrate coding expertise into AI tools, such as audit support and surveillance function. Many coders express concerns about AI replacing jobs. Do you anticipate AI will actually create new opportunities and expand the workforce instead? Great question for the group.
I'll take that to start. So again, where we're at right now, and I'm just being honest, I have not seen an NLP solution that's going to replace a coder. So yes, we need the coders. We need the auditors. We need folks that are able to go in and provide, again, that continuous feedback so that the AI can grow. Dr. Jan today talked about, bias and how we can make sure that we're keeping up with disease processes and post-COVID environments, and it's a constantly changing landscape. So yes, I think there's going to be more opportunities as far as expanding not your work, but how you do your work, right? Whereas previously it might just be, okay, I'm going to go through and audit this chart and see if anything was missed. It's utilizing that AI in your audit work, providing the feedback to the coder based on results that you're getting from that AI. I think that's going to be the future there. I think we're already there. You guys, a lot of you guys on this webinar are probably already utilizing AI and NLP in your workflows. So we still need you.
Yeah, it's interesting. Coders to become smart coders, right? That's the way I look at it. You are a coder, but now you're a smart coder because now, guess what? You have access to that something that can highlight unsupported diagnoses, right? Missing evidence. You're looking at reducing audit risk and ensuring meet, right? Which is your monitoring, evaluation, right? So I think there is an opportunity for coders to feel more empowered with this information that they have in their hands that they would not have had otherwise. So from my perspective, there will be more jobs is the way I see it, because there will be more that we will find that we are not doing. There is more that we should have done, which we can do now with the additional tools in our hands. And so it's more about it's not about losing the job, but adding to what job you do a little bit improvised, more probably sharper in a way that can happen. Plus, in addition to that, a more robust model that will give you a better risk score based on true data.
Yeah, I would just add, replace the word coder in there with physicians, right? There is this perception that generative AI and AI in general will start to replace a lot of things that we do. What I would argue with, at least in healthcare, there's such a shortage of resources and a shortage, especially among some of the skilled folks, that I think this really should be about how are we actually making the ability for what you all do much more extensible, and with a co-pilot or an assistant along the way, the efficiencies that are gained will allow us to do more with the folks that we do have. I don't know whether there'll be more opportunities, but I do know with the shortages that we have right now in taking care of individual patients, at least in the US, there's plenty of work, plenty of opportunity.
And while we
To
wait for,
add on that,
certainly I was going to
I just
say,
wanted to add one.
please add additional
Go ahead.
questions to the Q&A for the panel. We definitely want to be able to get those in, but Christy, I'll turn it back over to you so the group can keep typing their answers or questions in for you.
Sure. I just wanted to absolutely piggyback off what Dr. Jan said. So overall, AI isn't likely to replace people, but it's going to replace the pain points in their workflows. So if you kind of switch your mindset to think about it that way, it's like, oh, there's an easier way for me to do the work that I'm doing.
Definitely. And as we're seeing that really decrease in the administrative and operational burdens that are being there, what do you anticipate changing in the next year for you as AI co-pilots and agents come in to support you, Shri and Christy, as part of your workflows?
As part of our workflow, when you look at where we are thinking that this might actually be looking 5 years down the line, just, crystal ball out there. I think there is a lot of opportunity for us to do much more better in terms of how we can help the patients get better care, as a simple example, how we can utilize the data from multiple research opportunities out there that can really be beneficial. And lastly, I think there is a vast amount of data that's being unused in healthcare, huge amounts of data. We've just started getting somewhere into it. We've had EMRs for the past, 10 years, 10, 15 years, which we've not harnessed. And there are opportunities for us to harness that. There are opportunities to do better research. There's opportunities for pharma companies to do a phenomenal job of utilizing all of this data for much more robust drugs out there. I mean, think about studying GLP-1 interactions in a matter of 6 months. It could take years. With AI, we could get that done in a matter of days, depending on what you're trying to do. So there is opportunity there, and we need to make sure we can utilize the opportunity effectively in clinical workflows.
And Christy, we have a question that the audience would like you to talk a little bit more about what you're writing back to the EMRs and what you think should and shouldn't be go to the provider and into the note. And then Dr. Jen, of course, your thoughts as a clinician on what do you want to be seeing when they're querying you?
So I will definitely say any coding program compliance should be at the forefront, right? So, referencing the AHIMA query practice brief, as well as just regulatory guidance here. We know that queries should be clinically relevant. We should be asking the provider based on clinical evidence. We should never be asking a provider to evaluate or amend a note for something that they never documented. Yeah, we think about some of those whistleblower lawsuits, that's on the forefront, right? Making sure that our verbiage is compliant. Instead of saying, hey, doctor, evaluate for sepsis, we need to ask, here is the clinical evidence. Please evaluate whether or not you think the patient has sepsis as clinically appropriate, right? We want to make sure we add an open request there. I'd love to hear Dr. Jan's thoughts from as a clinician.
Great.
So I mean, as a clinician, Christy, I couldn't agree more. I think the back and forth that happens between the physicians and the coders, there's a huge opportunity for us to make that process a little bit more efficient, more transparent. I think that's what most of my colleagues who are still practicing medicine would expect. Taking my physician hat off and putting my sort of vendor hat on as Chief Innovation Officer for Innovaccer, I would think that the bar will move in terms of what needs to be present. Obviously, all the regulatorily required verbiage that you're talking about, Christy, absolutely needs to be in there. But I think there needs to be a much higher level of transparency, much higher level of proactiveness. You guys are the coding experts in terms of what can happen proactively versus concurrently versus retrospectively. I'm not going to get into that right now. But I think part of the challenge that physicians have, clinicians have, is at what point in the care process am I being nudged, and at what point do we know that there are things that are missed opportunities, if you will, from a best clinical documentation that may support the work that the coding professionals do. So I think if I were to predict the future, it's going to be that there's a class of issues that the coding professionals and the physicians deal with today that's going to be moved much closer to the point of care, and eliminate 80% of the back and forth. And then the 20% that remain are going to be the ones that are very, very complex, that require a little bit of discussions, if you will, or at least some thinking through. But I do believe that clinicians want a much more efficient, much more lower latency type of approach. Many of them don't remember what happened a week ago or even 3 days ago, and it may not be in their best interest. I do think that this will move over time. Again, Christy, you said the magic words. It has to be regulatorily compliant. No one wants to avoid or obviate that, but the process today for clinicians is not the most ideal process, as we all know, which is what we're all trying to solve together.
So if you could choose, what would be the AI co-pilot of your dreams to come in and help make your day-to-day life even more better that you have not seen yet? What are you hoping for in the next year if you could have that magic wand to grant that wish?
Let's
Yeah, I think
say
yeah.
the continuous automating of repetitive tasks, right? So chart retrieval, prioritization, flagging for incomplete templates. We maybe prioritizing, and I know that some of this is already in the works, prioritizing charts, right, based on closing gaps and suspect opportunities. With refining these models, we expect the AI to handle maybe pre-query draft creation. So that will free up the coders to focus on high complexity reviews. For providers, hopefully that will result in reduced query volume through that better kind of point of care prompts and the clinical documentation improvement suggestions there.
And Sri, what's on your wish list?
From my perspective, I think we have an opportunity to clean up data in healthcare. If we can use AI to really clean up data, we'll be much better clinicians and technicians, I can tell you. And the reason why I say that is because we have, we give, 5 minutes, 10 minutes, 15 minutes, and 8 minutes for somebody to get an RVU, right? But that doesn't consider all of the things that they need to do in order to create a good chart. And so if we can help those clinicians, people who are literally struggling to meet their timelines and trying to get stuff done and see as many patients as possible, and provide them with capabilities that it's in their fingertips, that is where I think we'll get much better charts, much better data, and much more leverage of the capabilities that AI can provide for the future.
Agreed. And having seen those problem lists, they keep growing year after year. Seeing AI being able to come in and clean up that problem list so it isn't pages as we get those documentation in. That's my wish list.
Just MedRec alone, right? Think about simple things like MedRec, problem diagnoses, the codes that is out there that nobody has looked at for 8 years that should be, basically redacted. I mean, there's so many things that we could do with AI to clean up our environment. And that will be phenomenal for not just for us, but for the future.
I think, Michelle, first of all, Sri, good luck in cleaning up the data, number one. It's people like me in a busy practice, especially on a Friday at 6 p.m. when you're seeing a patient, all sorts of reasons why the data isn't cleaner, but you're 100% right. Number one, we do need to clean it up. But what I would argue is that in the future, we need to get good clinical practice to be aligned to good coding practice or to good documentation practice. And right now, those two worlds are very different. When I'm seeing a patient and when my peers are seeing patients, they're doing so to take care of a patient. And that might not necessarily require me to pause or my peers to pause and start putting information in just to defend what it is that might be happening with the patient. And I think those two worlds will start to get closer and closer as we think about ambient documentation, as we think about scribing, as we start thinking about co-pilots that are helping physicians take better care of patients. The byproduct could be everything that Sri and Christy need in order to justify the level of billing and the level of documentation that's required. So I think these worlds will collide, but right now, let's all understand that these two worlds are not necessarily aligned.
Agreed. I appreciate your time today as we go through it. I know the members of the audience that have been joining us, we greatly appreciate their time as well. There is a feedback form that we'll be posting to you. We'd love to have your feedback for the panelists on what your thoughts were for today. If there are any additional questions, please post those in the Q&A. We'd be happy to follow up with those offline with our group. And we thank you so much for joining us today. It has been wonderful speaking with the three of you. I look forward to our future collaborations together. And again, thank you so much for joining us here at our webinar today.
Thank you, Michelle. Thanks,
Thank you,
Sri.
Michelle.
Thank you.
Thank you. Thanks, guys.